Of all the relationships that we have, jaw relations are the most complicated for dentists, right? Hello everybody and welcome back to our series on prosthodontics by Medical Sutras. Today we will be discussing about jaw relations and try to uncomplicate this troublesome topic for you. According to GPT-9, jaw relation or maxillomandibular relationship record is a registration of any positional relationship of the mandible relative to maxilla. These records may be made at any vertical, horizontal or lateral orientation. So we will be talking about orientation jaw relations, vertical jaw relations and horizontal jaw relations. Today we will be dealing with orientation jaw relations. The steps in recording jaw relation include: first, fabrication of occlusal rims. Detailed notes are available on our app Medical Sutras. Next is deciding the level of occlusal plane based on the interpupillary line, campus line. Then we have to orient the cast with the opening axis of the articulator and a Facebow record. Next we establish the vertical dimension of occlusion and then we determine the centric relation at the accepted vertical dimension. Establishing the correct level or height of the occlusal plane demands an understanding of the neutral zone concept together with the modiolus function and denture stability. Neutral zone is defined as the potential space between the lips and cheek on one side and tongue on the other, that area or position where the forces between the tongue and the cheeks or lips are equal, whereas modiolus is the area near the corner of the mouth where 8 muscles converge. It functionally separates the labial vestibule from the buccal vestibule. Now, according to GPT-9, there are 8 muscles in the modiolus. However, Gray's Anatomy lists 9 muscles which together form the modiolus. It includes orbicularis oris, buccinator, levator anguli oris, depressor anguli oris, zygomaticus major, risorius, quadratus labii superioris, quadratus labii inferioris, and the 9th muscle is zygomaticus minor. So the question that was asked in 2001, modiolus at the corner of the mouth is formed by all of the following except, when we look at the options, the correct option here is C, because masseter does not decussate in the modiolus. Which muscle does not decussate in the modiolus? The options are levator labii superioris, orbicularis oris, zygomaticus major and buccinator. The correct answer here is A, that is levator labii superioris. The modiolus becomes fixed every time the buccinator muscle contracts, which is a natural accompaniment of all the chewing efforts. The contraction of the modiolus presses the corner of the mouth against the premolars, so the occlusal table is closed in the front. Food is crushed by the premolars and the molars and does not escape at the corner of mouth. The corner of the mouth are marked on the occlusal rim to provide the dentist and technician with anterior landmark for the height of the first premolar. The anterior 2/3 of the retromolar pad marks the posterior landmark. Joining two landmarks results in occlusal plane almost invariably parallel to the residual alveolar ridge and to the interpupillary line. The maxillary occlusal rim is next adjusted to meet evenly with the mandibular rim. In another technique, the starting point for establishing the occlusal plane is the maxillary occlusal rim. The procedure entails shaping the occlusal rims so that the incisal plane is made parallel to the interpupillary line and is at a height that allows for the length of the natural tooth plus the amount of tissue resorption. The occlusal plane posteriorly is made parallel to the ala tragus line on the basis of the position of the most natural occlusal planes. Then the lower occlusal rim is adjusted to meet evenly with the upper rim and reduced until sufficient interocclusal distance has been obtained. Now moving to our topic proper, the orientation jaw relation according to the Boucher's 10th edition are those that orient the mandible to the cranium in such a way that when mandible is kept in its most posterior position, the mandible can rotate in a sagittal plane around an imaginary transverse axis passing through or near the condyles. First, we need to understand about the hinge axis. GPT-9 defines it as an imaginary line along which the mandible may rotate within the sagittal plane. According to Hartwell, hinge axis is an imaginary line around which the condyles can rotate without translation. The opening axis is an imaginary line around which the condyles may rotate during the opening and closing movements of the mandible. Terminal hinge axis. So now when the condyles are in the most superior position in the articular fossa and the mouth is purely rotated open, the axis around which this movement occurs is termed as the terminal hinge axis. Pure rotation of condyles takes place in the first 10 to 13 degree arc of mandibular opening and closing, or during the initial mouth opening of 15 to 20 mm. Clinically, the location of transverse hinge axis serves only to orient the maxilla and to record the starting point for functional mandibular movements. It does not record the centric relation or the condylar movements. It allows the transfer of the opening axis of jaws to the articulator so that the occlusion would be on the same arc of closure and in the patient's mouth. The axis recording is required to check the accuracy of two centric records. Vertical dimension of occlusion can be altered on the articulator. It helps in proper positioning of the casts in relation to the intercondylar shaft. GPT-9 defines Facebow as a caliper-like instrument used to record the spatial relationship of the maxillary arch to some anatomic reference point or points and then transfer this relationship to an articulator. It orients the dental cast in the same relationship to the opening axis of the articulator. Customarily, the anatomic references are the mandibular condyles, transverse horizontal axis, and other selected anterior point. Boucher's 12th edition defines it as a caliper-like device that is used to record the relationship of the jaws to the opening axis and to orient the cast in the same relationship to the opening axis of the articulator. Now let's answer this question. Facebow measures the relationship of maxilla to opening and closing axis, mandible, zygomatic bone, none of the above. The answer is A, as we have already discussed. Hinge axis Facebow records relationship of the teeth to the axis of rotation of the jaw, or the relationship of maxilla to mandible, or the relationship of mandible to the cranium, or all of the above. The answer is that it records the relationship of teeth to the axis of rotation of the jaw. Now the parts of the Facebow includes the U-shaped frame, orbital pointer, earpieces, bite fork, anterior elevator, the transfer clasp assembly, a mounting jig, and a locking device. Facebow is classified as the arbitrary Facebow and the kinematic Facebow or the hinge bow. Arbitrary Facebow is further divided into fascia type and earpiece type. The arbitrary Facebow is placed with the condylar rods located approximately over the condyle. The fork is attached to the maxillary occlusal rims. A minimum error of 5 mm from the axis can be expected, whereas the fascia type Facebow utilizes approximate points on the skin over the temporomandibular region as the posterior reference points. These points are located by measuring from certain anatomic landmarks on the face. The arbitrary Facebow uses the external auditory meatus as a reference point which is aligned with the earpieces similar to those on the stethoscope. They do not require measurements or works on the face. It provides an average anatomic dimension between the external auditory meatus and the horizontal axis of the mandible. They give sufficiently accurate relationship for most diagnostic and restorative procedures, and they are very simple to use. The advantages include: it aids in securing the antero-posterior cast position with the relation to the condyles of the mandible. It is an aid in the vertical positioning of the cast on the articulator. It registers the horizontal relationship of the casts quite accurately and thus assist in correctly locating the incisal plane. The Facebow transfer allows a more accurate arc of closure on the articulator when the interocclusal records are removed and the articulator is closed. Facebow essentially records the positional relationship of the maxilla to the condyles in centric relation and later transfers this relation to the articulator so that the maxillary cast is mounted in the same spatial relationship. Now, to change the patient's vertical dimension, the following record is needed. First is interocclusal record. second graphic records, third kinematic facebow, and D arbitrary facebow. The correct answer here is kinematic facebow. Hinge access is located with the help of A. Ear rods, B. Maxillomandibular vertical relations, C. Kinematic facebow, and D. Orbital pointer. Here also the correct answer is kinematic facebow. Now let's move on to the various anterior reference point. The first point that we will be talking about is orbital. Orbital is actually a bony point located at the lowest point of the infraorbital rim of the skull, which can be palpated on the patient through the overlying tissues and the skin. One orbital and two posterior points that determine the horizontal plane of rotation will define the axis orbital plane. The second reference point that we'll be talking about is the orbital -7. Because porion is a skull landmark, Sitter recommends using the midpoint of the upper border of the external auditory meatus as the posterior cranial landmark on the patient. The anterior point of reference marked 7 mm below the orbital on the patient, or position the orbital pointer 7 mm above the orbital indicator of the articulator. Here the FH plane becomes the horizontal plane of reference. The third is Nazian -23. The Nazian guide or positioner or relator of the quick mount facebow, which is specifically designed to be used with the Whitmex articulator, fits into the depression located in the head at the deepest part of the midline, just below the level of the eyebrows. This Nazian relator can be moved only in an in and out motion and not in an up and down motion from its attachment to the facebow crossbar. The crossbar is located 23 mm below the midpoint of the Nazian pointer. Next is the 43 mm superior from the lower border of the upper lip. Guchet has emphasized that the logical positioning for the cast on an articulator would be one, which would position the plane of occlusion near the mid-horizontal plane of the articulator, that is 43 mm superior from the lower border of upper lip. This is termed as the Denard reference plane locator. Next, we will be talking about the ala of the nose. A line drawn from the ala of the nose to the center of the auditory meatus can be described as the Camper's line. The dentist can transfer the Camper's line from the patient to the articulator by marking the right or left ala on the patient as the anterior reference point of the facebow and the hinge points posteriorly. These are various other anterior reference points. The ones that we have discussed are the ones that are most commonly asked. The posterior reference point includes A. Bayron point, which is 13 mm anterior to the posterior margin of the tragus of the outer canthus of eye. B is Guy's point, 13 mm anterior to the anterior margin of external auditory meatus. C is Snow, which is 11 to 13 mm anterior to tragus. D is Denard's, 12 mm anterior to the posterior border of tragus and 5 mm inferior to a line drawn from the EOM and outer canthus. Last is Bergstrom's point, 10 mm anterior to the center of spherical insert of the facebow and 7 mm below the FH plane. Bayron point is located at, this is a direct question. The correct option here is A. 13 mm anterior to the posterior margin of the tragus on a line drawn from the center of the tragus to the outer canthus. This was asked in AIPG 2005. Now we'll talk about the kinematic facebow records. The first step in these records is the fabrication of clutch for the mandibular arch, and then the horizontal stem is attached to it. The hinge bow or the kinematic facebow is attached to the stem of the bite fork, and the condylar rods are located at a point 13 mm in front of the auditory meatus on the canthotragus line. The patient should be placed in a semi-supine position and his mandibles should be guided to produce opening and closing movements which are purely rotational. The condylar rods will move. They will either rotate or translate depending upon the movement of the condyles during these mandibular movements. The point at which the condylar rods show pure rotation indicates the terminal hinge axis. If the patient opens his mouth widely, that is more than 12 to 15 degrees, then the condylar rods will move anteriorly and they will translate. The use of kinematic facebow is contraindicated in the edentulous patients because It has to be used on the mandibular ridge. Recording bases may be unstable on the edentulous mandible, and movement of the bases will lead to inaccuracy in recording the hinge axis. The correct answer here is D, that is all of the above. It was basically an explanatory question that tells us that the kinematic facebow is contraindicated in the edentulous patient due to the reasons listed below. Now when we talk about the steps in recording the arbitrary facebow, first we have to place a softened bite registration material on the bite fork and make an imprint of the maxillary occlusal surface such that the midpoint of the bite fork is matched with the center of the patient's face, and the stem of the bite fork is kept parallel to the mid-sagittal plane and to the patient's left. Then we slide the U-frame along with the transfer assembly over the stem and insert the earpieces into the external auditory meatus of the patient. The orbital pointer is made to coincide with the infraorbital notch of the patient. The assembly is then slit to the right or left so that the center of the face, the marking on the bite fork and the vertical rod of the transfer assembly are all in the same straight line when viewed from the front. Lock the thumb screws in the order as shown. After the facebow records are made, next we have to go for transferring the facebow records onto the articulator, that is mounting. The mounting can be done directly as well as indirectly. In direct mounting, after the facebow registration has been obtained and the earbow halves have been removed from the subject, the facebow is transferred directly onto the articulator to mount the maxillary cast. Whereas in indirect mounting, once the facebow registrations has been obtained, the transfer assembly is removed from the spring bow and placed on the articulator using the transfer jig and the mounting platform for mounting of the maxillary cast. So now this concludes our discussion about orientation jaw relations. We will see you again with our discussion on vertical jaw relation next. Till then, if you found the video helpful and informative, then do like the video, share it with your friends and also subscribe the channel for more such content. Also, you can download our app Medical Sutras for more such detailed notes on dental and medical topics. You can also comment below on any other topics that you want us to cover for you. Have a good day.